Hello, welcome to our presentation on a review of practice of analgesic techniques in major urological surgery at Broomfield Hospital. My name is Conor Nnochiri. I'm one of the anaesthetic CT2s at Broomfield. My colleagues who worked on this project are Dr. Rory Dennis, one of our previous SHOs, Dr. Danny Fawkes, one of our previous senior registrars, Dr. Tom Atkinson, one of our consultants, and the consultant overseeing the project was Dr. Al Hughes, the perioperative lead for Mid and South Essex. The laparoscopic approach to nephrectomy has reduced postoperative pain scores and analgesic requirements when compared to open procedures. Nevertheless, the search for the optimal analgesic strategy continues, and the provision of analgesia for these cases varies significantly at Broomfield. Anaesthetists that favour subarachnoid block have been trending towards the use of higher dose intrathecal diamorphine. Therefore, the reason for this project was to have a particular focus on the use of higher dose intrathecal diamorphine and to look for the presence or absence of opioid-induced ventilatory insufficiency in these patients. Whilst doing so, we'd review and quantify analgesic techniques for major urological surgery. We performed a retrospective case note review for all adult patients who had major urological surgery between the 4th of September 2017 and the 28th of April 2021. Interrogation of our electronic database identified 159 patients. We successfully obtained 109 case notes, however 4 sets of notes were excluded due to incomplete data. The remaining 105 notes were then reviewed. For patients who received the subarachnoid block, we also recorded dose of diamorphine and the occurrence of opioid-induced ventilatory insufficiency. We also recorded additional analgesic use in recovery, postoperative destination, and postoperative complications. Traditionally, 300 mics of intrathecal diamorphine has been widely used for such operations. Therefore, we classed higher dose intrathecal diamorphine as 400 mics or greater. Looking at our results, we found that 92% of procedures were performed laparoscopically. All open procedures underwent neurolaxial techniques, whereas for laparoscopic surgery, peripheral regional techniques were predominantly used, with quadratus lumborum blocks being used the most frequently. 26 patients underwent a subarachnoid block. 88% of them received higher dose intrathecal diamorphine with a median dose of 600 mics. The dose ranged from 3.7 to 11.29 mics per kg. 48% required additional analgesia and recovery, which was most commonly intravenous fentanyl. There were no cases of opioid-induced ventilatory insufficiency. This was reassuring despite a small sample size. Further information on postoperative complications and postoperative destination can be found on our poster. Thank you to the Anaesthetic Department and the Health Record Centre at Broomfield Hospital, and thank you for listening.